you want to see it, huh? Okay, so we finished on antiemetics. Antiemetics is one of the drugs that we use almost with, I would say, 90% of our patients. Because of the area we're treating. Remember that the side effects depend on the area we're treating. If we're treating the chest, you don't get nausea or vomiting because you're not treating that area. If we're treating the abdomen, you don't get a sore throat. It may sound silly, but some people think that they're going to get everything under the sun. Why am I not being nauseous and vomiting? Well, we're only treating the ear. So, antiemetics can mask the cause and should not be used until the cause is determined, which makes sense. If you're nauseous, if you're vomiting, there has to be a reason why. And until you figure out the reason why, you shouldn't give any anti-nausea medication. Same as painkillers. If you're not sure why the pain is there, you shouldn't be using painkillers. So we have the vomiting center and the vestibular center and the chemoreceptor. So it depends on what is causing the vomiting. Obviously, if it's chemoreceptor center, then and you're getting chemo, then the chances are that that's what you're doing. The vomiting center, however, if you've ever been nauseated and then someone starts frying something in the kitchen and you smell it, and you think, then off you go. I think the worst thing is if you're, as a radiation therapist, that's happened, not to me, because that's not one of my bugs, but we had a girl who couldn't stand vomit. She was one of these, anyway, she was standing there, first time I ever saw her do it though. She was standing there and the lady was vomiting and she was standing holding a bucket. And poor lady was vomiting and this girl started going, and eventually started, so the pair of them were starting vomiting in the same bucket.
Ew. Oh,
Yeah, not the best thing for a professional to do, but yeah. As it turned out, she was pregnant and nobody knew, so that's probably why she, anyway. But, you know, we all have our things. I don't have many of them, but I have, everybody has one or two. So, non-pharmaceutical. I think we went over this, but it's well worth going over it again. Weak tea, flattened carbonated drinks, Gatorade, Pedialyte, crackers and dry toast. Anyone who's ever been pregnant knows that the crackers and dry toast, flattened carbonated drinks. The best one is ginger ale, flattened ginger ale. I never have managed to get a taste for Gatorade, but anyway. Non-prescription antiemetics. So we can buy Dramamine over the counter. That is a officially a motion sickness med, but it works. It doesn't help the severe vomiting, but it helps if you're just sort of nauseated. But they do make you tired. So, as the package says, do not drive, do not use any large vehicles or machinery or whatever it happens to be. Take 30 minutes before traveling. So there's your Dramamine. Also, Benadryl. Has anybody taken Benadryl for an allergy and fallen asleep? Yeah. So it's a good sleep aid as well if you really want to use it that way.
Any allergy medicine makes me fall asleep.
Yeah.
Anything non-drowsy, Zyrtec, all that stuff.
Even if it's non-drowsy.
Yeah, I've got every single allergy medicine, just can't take it unless I can sleep for like 2 days.
Yeah. Well, that's it. You know what I mean? Yeah, you have some people who take Benadryl and they're hyper.
What?
I don't understand it myself because I fall asleep if I take Benadryl. So, same as coffee.
I used to be like
There are
that.
some people who can drink coffee at 10 o'clock at night and still be wide awake, or still to go fall asleep. Most people, they drink coffee at 7 o'clock at night and they're up for days. It's just one of these things. However, you give infants coffee or caffeine, and they'll fall asleep. Most infants. There are always the odd ones out. Okay. Pepto-Bismol. Not only can you use it for diarrhea, but you can use it for an upset stomach. Acts directly on gastric mucosa to suppress vomiting. Liquid or chewable. Who was saying that Pepto-Bismol made their tongue black or blue or whatever it was?
I love the way it tastes.
The tablets that you
The tablets, the chewables, yeah. I must admit I've never taken Pepto-Bismol.
I used to get made fun of because I said it tastes good, but that stuff tastes so good to me. I don't know why.
That's disgusting.
Oh, you're one of those people.
It tastes like a really good drink. I don't know why.
Okay. Now, I must admit, I think it's the pink that puts me off. I mean, it just doesn't look.
Yeah.
Anyway. So, I mean, if you can take Pepto-Bismol, whether it's liquid or chewables or whatever it happens to be, and it works on your vomiting, by all means take it, or even the nausea. Same as for diarrhea. If whatever works, take it. Emitrol decreases nausea and vomiting by changing the gastric pH. So antiemetics were used in the first trimester of pregnancy, but they're not used unless there's an excellent reason why it should be. Scopolamine and phenigrin. Phenigrin is used quite a bit in radiation therapy for normal antiemetic. Scopolamine is sometimes used for travel sickness if you're on boats, if you're on ships, or actual boats, not ships, but scopolamine sometimes works. All of these, they work for most people, but sometimes they don't work for certain people. Side effects, drowsiness, surprise, surprise, dry mouth, blurred vision, tachycardia, and constipation. So you really don't want to use them unless you're sure they're gonna work and the patient knows about the side effects. Dopamine antagonists. So side effects, tremors, face mask face, rigidity and shuffling gait, which is the signs and symptoms of Parkinson's disease, yeah, because dopamine is one of the drugs that is used for some of the early stages of Parkinson's. Phenazines, so thorazine, compazine, and trilafone. So compazine is another one that is used quite a bit in radiation therapy. Thorazine, do you know what that's used for?
Either schizophrenia or.
Yeah, it's an antipsychotic. Yeah, it's an antipsychotic. Thorazine is also, who was saying something about hiccups? Somebody was saying hiccups on Wednesday.
Oh, like if you had hiccups, somebody had hiccups during the.
Yeah, during the treatment, yeah. So Thorazine sometimes is prescribed for those people to try and stop the hiccups. And it works. I'm not sure how it works, but it works. Inhibits dopamine and therefore decreases stimulation on the vomiting center. Severe nausea and vomiting from surgery, anesthetic, chemo and radiation sickness. Dry mouth, drowsiness, dizziness and hypotension. Used with anti-cancer therapy, inhibits dopamine. So onset 2 to 6 hours, duration 6 to 12 hours. So it can take 2 hours to actually work, this one. Interactions, taking with, what's ETOH? Alcohol, yeah. Anti-hypertensive agents and nitrate. Hypertension can result. And what's hypotension?
Low blood pressure.
Low blood pressure, yeah. CNS depression when taken with alcohol, narcotics, sedative hypnotics, and general anesthetics. So you read all this stuff and you wonder why MD actually uses it. Haloperidol or Haldol, again, they're used a lot for antipsychotics. So again, you have these side effects. Lorazepam or Ativan. Everybody knows Ativan. May be given with an antiemetic such as Reglan. Serotonin antagonists. Ondansetron. Or the name is Zofran actually. Or Kytril. Kytril is another one. So they suppress nausea and vomiting by blocking the serotonin receptors. And they are, ondansetron especially, Kytril to a certain extent, is used a lot for nausea and, vomiting from both chemo and radiation. That's what we pre-med our patients that we're treating the inverted Y. We use ondansetron. And we tell them, we tell them to take it an hour before they're going for treatment. When this first came on the market, we thought this was great, till we found out it was $5 a pill.
How long do they have to take it?
All the time they're on treatment, well, we wanted them to take it an hour before treatment and then as needed after that.
Oh, so you take more than one a day.
Oh, yeah. Yeah. So we sort of cut it back, shall we say. We used ondansetron for pre-med, and then we gave them another antiemetic to use afterwards. And that seemed to work. And most of these are all PO. The only problem is that if you're actively vomiting, you really can't use an oral medication, can ya?
There's some of that dissolve on your tongue.
Hmm?
You can chew them. You can chew them too.
Yeah, but if you're actively vomiting, you can't really take anything by mouth, whether you're going to swallow or chew it. So they do make suppositories.
What about patch?
What? No, not these ones, no. They're talking about doing patches, but at the moment they're not doing them. So the side effects are headache, diarrhea, dizziness, and fatigue. Corticosteroids, Decadron, effective with chemo-suppressing effective with chemo treatment in suppressing emesis, but this has to be given IV. Although you can take Decadron by mouth, when you're using it as an antiemetic, it works better IV. Cannabinoids. Active ingredient in marijuana, approved for clinical use since 1985 to alleviate nausea and vomiting from cancer treatments. Nabalone is the one that I've seen used quite a bit, especially in California for some peculiar reason. But clinical use since 1985, depending on where you happen to be at the time, of course. I know that a lot of our patients that we were treating, inverted Ys and seminomas, before marijuana came into the clinical picture, would go out and buy it off the streets to help with the nausea and vomiting, and it worked. The physicians would ask them how they were feeling, and they would say, "Oh, fine, you got something for the nausea? Yeah. Did we give it to you? No. Is it working? Yes. Okay. I don't want to know." Because they officially couldn't know. They knew, but they weren't allowed to ask. Which is, when you think about it, it really doesn't make sense. But at that point in time, this is mid-80s in Canada, we couldn't ask. We did ask, but the physicians couldn't ask. As long as it worked. Pardon?
That's a lot of side effects.
Yeah, but if you've got uncontrolled vomiting from treatment and nothing is working for you, and cannabis or nabalone these days, or marijuana off the street works for you, why not? I don't think we ever had anybody got caught by the police for doing that, but they never told us anyway if they did. So, side effects. Mood changes, euphoria, drowsiness, nightmares, dry mouth, confusion, headaches, depersonalization, nightmares. Did we do nightmares? Yeah, we did. Incoordination, memory lapses, orthostatic hypertension, and tachycardia. Now that is quite some side effects, but not everybody gets that same side effect. So these are the miscellaneous ones. I've never seen any of those used, but obviously they are to a certain extent, but not necessarily for our treatment. So labeled miscellaneous because they don't act strictly as a antihistamine, antichloronetic, or phenothiazides. Drowsiness, CNS stimulation. Oh. Okay. Oh. We've done this. Okay. So, non-pharmaceuticals for antidiarrheal. Clear liquids, Gatorade, Pedialyte, IV electrolyte solutions. 4 categories: opiate-related agents, absorbents, antidiarrheal compounds. So tincture of opium, paregoric, or codeine, in combination with other agents. Side effects, CNS depression. I don't think anybody would actually prescribe opiates for diarrhea. Not anymore. Used to, but not anymore. Opiate-related agents, so Lomotil. Lomotil, it's a wonderful drug, swear by it. Anyway, or Imodium.
What does that mean, opiate related?
Lomotil has an opiate in it. It has a mild opiate in the combination.
Also?
Pardon?
Does Imodium also have an opiate in it?
No. No. So synthetic drugs chemically related to meperidine, an action decreased intestinal motility, for example, traveler's diarrhea. When we were traveling in China, did I tell you we did an exchange trip to China? We did an exchange trip to China in 1985, and it was through the medical physics guys. So we all went to China, went into Hong Kong, and then 3 weeks in mainland China, and then we did Hong Kong and we did Japan on the way out. But the physician who was on the trip prescribed us all Lomotil because we didn't know what kind of food we were going to get. So he said, here, get the prescription filled, take the pills with you, and then you can use them or not. And he gave us all Lomotil. because it worked like blazes. And most of us during that trip were on, both my now husband and I were at one point on white rice and Coke, Coca-Cola. That's all we could keep down. Because, so we had to take the Lomotil. But it was worth it, it was good fun, great fun. We traveled all over China. One of these days I'll actually tell you stories about it. So again, antidiarrheal. Imodium works against diarrhea longer than the similar dose of Lomotil. Lomotil is approximately, there's your answer, 50% atropine to discourage abuse. So action time is 45 to 60 minutes, duration 3 to 4 hours. Side effects due to atropine, dry mouth, urinary retention, and decreased secretions. But obviously you don't take, we took one. I remember taking 2, and the diarrhea was wonderful, stopped. So absorbance, coat the wall of the GI tract, so this is where kaolpectin comes in. Kaolin is basically chalk, and the pectin, and it's over the counter, same as Pepto-Bismol. You can choose what you want. They both come in liquids and the pills. Kaolpectin is white. Obviously Pepto-Bismol is pink. So you can choose what you like. So constipation, why would we be talking about constipation with radiation therapy patients? Do we have patients who are constipated? For how? Why? What makes them constipated?
Painkillers.
Pardon?
Certain painkillers.
Certain painkillers, yeah. So the most common one as far as we're concerned, is opiates or pain medications. They make you constipated. Accumulation of hard fecal material in the large intestine, a major problem in the elderly, because they don't tend to drink as much fluids and they're not as good with their diet. So causes poor water intake and poor dietary habits, ignoring the urge, fecal impaction, bowel obstruction, chronic laxative use, neurological disorders, for example, paraplegia, lack of exercise, selected drugs, narcotics, and certain antacids. So, non-pharmaceutical treatments. Diet that contains fiber, water, and exercise. Routine bowel habits varies from person to person, and frequency is secondary to consistency. The last thing you want to do is have a patient who is impacted, which means, anybody any idea what impacted means?
Full of poop.
Full of poop. Yeah, okay. Very colourful, but yeah, exactly. What happens sometimes then is they have to go into the ER and they're manually disimpacted. So in other words, somebody has to go in and pull the poop out, which is not very pleasant for anybody. So, pharmaceutical or pharmacological measures. Laxatives increase peristalsis, promote soft stool, and cathartics result in soft to watery stool with some cramping. use painful elimination due to episiotomy, hemorrhoids and anorectal lesions, cardiovascular disease prior to surgery or tests. Laxative abuse from chronic use, a problem, especially with animals. Okay, so what would amount to laxative abuse? We do have some patients that do that, have that problem. There are some people who, if they don't go on the hour, every hour, or whatever it happens to be, they'll take laxatives. We had a lady that I worked with in California that used to do daily enemas. Yeah. And we asked her why at one point, because I've always done it. And it's good for the bowel, it cleans everything out. And we said, yeah,
No.
but.
You clean yourself
And
out.
she, as soon as you mentioned something about it's going to go wrong, she just shut off. She wouldn't listen to you anymore. So, yeah. How she managed to do it, I'm not sure, but she did it.
Oh, my great grandmother is. She's like, she insists that dried apricots is in it. I'm like, she's like 94.
Yeah, well, at
She,
94,
like,
yeah. So dried apricots.
It's old people.
I'm like, okay.
They're stuck in there.
She's like, I haven't gone today. I need apricots.
Yeah.
Oh my gosh.
Well, and then this is the problem with, and this stems from what is diarrhea or what is constipation. You have some people who go, they defecate 3 times a day. You have some people who do once a day. You have some people who do every 3 days. So if you have someone who poops every 3 days and they suddenly have to go every day, to them, that is diarrhea. Or if they don't go every day, then they're constipated. So out comes the laxatives or the other situations. So, but apricots, well, any fruit really is quite good. If you can keep your bowel moving through, what do you need? Fiber, healthy fiber diet,
Hydration.
fruit and vegetables, and hydration. Osmotic laxatives. So, include salts and saline products, lactose, and glycerin. Magnesium hydroxide, sodium biphosphate. Here's your flea enema. That's what most of the enemas are. They call them flea enemas. And that is basically sodium biphosphate. And they work, but they're not meant to be used every day.
Feels weird.
And there's some people who use, and this is weird. I know it sounds weird. Coffee enemas.
What?
All you have to do is drink coffee.
Coffee enemas. It doesn't work the same way, right?
Oh, it does.
So, yeah,
just have to
so
look
these
at
poorly
coffee.
absorbed salts, osmotic action draws water into the intestines, increasing water, causes fecal mass to soften and swell, stretches intestine, and simulates peristalsis. And that's what we need, is peristalsis to get things through the bowel. So saline preps contain sodium and magnesium, small amount, maybe systematically absorbed, so it can work with poor renal function. Polyethylene glycol, non-absorbable osmotic substance, can be used by clients with renal impairment or cardiac problems. PO 3 to 4 liters over 3 hours for bowel prep. That sounds like what you have to do colonoscopy. So anything that will draw water into the intestines is working. Clients with, what's this?
Congestive heart failure.
Pardon?
Congestive heart failure.
Yeah, chronic heart failure. With renal insufficiency, should avoid magnesium salts in some laxatives. For example, most people have heard of milk and magnesia?
Yeah.
Yeah. With CHF, you shouldn't use that. Electrolytes should be monitored. What happens with, we've done laxatives. So what happens with electrolytes? If your electrolytes are low, what would the patient's actions be like if your electrolytes were out of whack? Lethargic, okay? Pardon? If your electrolytes were out of whack, you would be acting as if you had something wrong with your brain. You would be acting, your personality might change. You may be slurring your speech. You may not be walking straight and level. So we've had several patients that we've looked at, and because the patient has lung cancer and they started acting like this, we've asked for the doctor to come see them because we thought that they may have brain mets, which is a reasonable thought. Turned out that their electrolytes were all out of whack. And they were acting silly, so they get them electrolytes in and they're back to normal. So you have to be careful in that one. But it's better, as they say, it's better safe than sorry. Treat them as serious until proved otherwise, basically, is what we're talking about. So stimulant or contact laxatives increase peristalsis by irritating sensory nerve endings in the intestinal mucosa. X-Lax, Dulcolax, Senecot, and castor oil. I didn't think anybody used castor oil anymore, but anyway.
People do it to like go into labor.
Hmm?
People do it to like go into labor. I don't think they do it as much anymore, but
No.
Yeah, to go into labor.
So you've got
Definitely not
X-Lax,
true.
Dulcolax, and Senecot, which are basically over-the-counter laxatives.
Overdose on laxatives.
You can overdose on anything. It's just not good for you. You can't really, I guess you could do harm if you OD'd on the likes of Dulcolax. Two of the most frequently used and abused laxatives over the counter. Biscadil, And so X-lax and Dulcolax are the most used and abused laxatives. So I guess you can abuse them. Castor oil. Harsh laxative that acts on the small bowel and produces watery stool, just what you need after being constipated. So, nausea, abdominal cramps, weakness, fluid and electrolyte imbalances with chronic use. So again, you have these people that take Senecod or X-lax or Dulcolax every day. They're not meant to be used every day. Bulk forming laxative, Metamucil, Pharmacology, Citrusal. So those natural fiber substances that promote large soft stools by absorbing water into the intestine, increasing fecal bulk and peristalsis. So everything works slightly differently. And again, the commercials say you can use them every day. As long as you don't overdo them, I guess. Does not cause laxative dependency and may be used by clients with diverticulosis, irritable bowel syndrome, ileostomy and colostomy. You really don't want to have a colostomy patient with either watery stool, which can make such a mess, or constipation. Powders mixed with water or juice, drink immediately, followed by a full glass of water. Okay. So emollients, surfactants, stool softeners, surface acting drugs and lubricants used to prevent constipation, straining during defecation. So there are laxatives and then there are stool softeners. So stool softeners are used before you start using laxatives, right? Lower surface tension and promotes water circulation in the intestine and stool. Used after an MI post-op. Side effects, nausea and vomiting, diarrhea and cramping, lovely. Okay, anti-ulcer drugs. I don't think we really need to know this, unless you're interested. Don't really need to know this. I'll be sending you these anyway, so you can look at them. Anti-ulcer, 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 anti-ulcer.
All the way to the end.
All the way to the end, okay.
That's a whole lot of anti-ulcer.
Yeah, whole load of anti-ulcers. So, okay, pain management. Okay. Pain management. Oh, no, that's not the one I wanted. Okay. I'm doing the other one. Okay, pain management. As we mentioned, pain is a matter of personal opinion. Some people have a lower pain threshold than others. If the patient says they're in pain, they're in pain. You may think, oh, can't be in pain for that, with that. But yeah, if the patient's in pain, they're in pain. Understand how the management of pain affects quality of life. This is long-term care facility patient. develop an awareness of misconceptions and consequences of untreated pain. Different types of pain. Identify appropriate analgesics for each type. So what's the two different types of pain? Two main different types of pain.
Physical and emotional.
No, not really. So we have chronic and we have acute.
So
We'll get
two
into the-
main types of physical
Into the
pain.
main things, yeah. So chronic or acute. And then we'll get into what causes the other four types of them. So utilize pain assessment tools as needed. Understand how to determine correct doses of analgesics and understand that all team members have their own assessment. Okay. Pain is what the patient says it is. Pain is totally subjective. In long-term care, residents do not always verbalize the pain but express it in other ways. This is basically the same as our patients do. They don't necessarily, unless you physically ask them outright, how's your pain? They'll answer you. But there's other ways that they can express it. So why are long-term residents at risk, increased risk for drug interactions? Why would you think somebody in a long-term care facility is more likely to have a drug interaction?
Do we have tissues?
What are you looking for, Jen?
Tissue?
Tissue?
No? Okay.
No, sorry. Have they got tissues? I have some in my office, so I'll bring them in. Hang on, no, it's okay. I'll go get them. I'm sure I've got them in my office.
So difficult.
You're welcome, first of all, because I don't know how. I understand that, but I'm cheap very good.
There you go.
Thank you.
Uh-huh.
I'm slowing the whole way, so that I'm not too loud.
Okay. Okay, so anybody tell me why, anybody tell me why somebody in a long-term care facility might have an increased risk of drug interactions?
They're older.
They're older, yeah, they have a lot of medical problems, therefore they have a lot of meds, therefore there's more likelihood of a drug interaction. Good. Okay. Pain is common at end of life as a result of arthritis, circulatory problems, disorders, immobility, neuropathy, cancer, and other age-related conditions. Everyone experiences pain differently. Older patients report pain differently. Institutionalized elderly are often stoic about pain. One person's report of severe pain may seem like almost nothing compared to another. Caregivers' challenge is to assess all relevant factors without imposing personal biases. If you happen to have a high pain threshold, then you have to make sure that you do not think that the patient is inflating their pain because you don't think that it's bad enough that they would cause pain. Or vice versa for that matter. if you have a low pain threshold, then you have a patient who is obviously in severe pain, but is saying, oh, I'm fine, as long as I don't move, I'm okay. And as soon as they move, they start to grimace. They're obviously in severe pain. So residents' self-report of pain is the single most reliable indicator of their pain. Residents may not have pain when not moving, and caregivers report pain when he or she is moving or doing advanced or daily living somethings. Everyone caring for the resident must know or recognize or report pain. Be influenced by the availability of pain management programs and training, expertise and experience of its members. So, misconceptions. Person with pain will always have obvious signs such as moaning, abnormal pain medication, or not eating. Will a patient or a person who is in pain always have these obvious signs?
No.
No. Some people don't. Some people do, some people don't. Pain is a normal part of aging. Is that a myth? Pain is not a normal part of aging. Addiction is common when opioid medications are prescribed. As long as you can keep the medication or the doses of the medication under control, then you should have no problems with addiction to those types of patients. And let's face it, if you're in a long-term care facility, addiction is the last thing on your mind. You want to get the patient comfortable. This is where hospice comes in. Everybody heard of hospice? So what is hospice? Pardon?
Palliative care.
End of life care, palliative care. So what's the difference between hospice and pain control in a hospital?
Hospice is usually like terminal illness.
Say again?
Hospice patients usually have like a terminal illness.
Okay. But then you have patients in having pain control in hospital that also have,
Maybe it's not the end of
Higher
their life.
prescriptions.
pardon?
Maybe they have higher prescriptions in hospice.
I think hospice is like the last.
They're not worried about you getting addicted in hospice.
It's like the last of your life. You can have pain care as a patient or as a terminal illness, but maybe you'll have a few months before you live. I feel like hospice is like you're almost done.
So do people actually go into hospice and then come out again?
Usually not, but
Usually
they can.
not, but there are patients who do. They rally and say, I don't want hospice anymore. The worst time is actually trying to get a patient into hospice, to persuade them that it's time to go into hospice. So are hospices inpatient facilities, outpatient facilities, or what do they do? Pardon? Some of them are inpatient. They have actual hospice buildings, and others go out to the community and the patients live at home. And everything is taken out, so they'll provide hospital beds, they'll provide IV poles, they'll provide basically anything that the patient needs in hospice. Okay, morphine or other strong pain relievers should be reserved for the late stages of dying. Is that true?
No.
No, it is wrong. You should be able to have patients on morphine or other strong medications without them in the hospice stage or palliative care stage. That being said, the majority of patients that are on morphine are usually palliative. That doesn't mean to say that the hospice, just because they're palliative doesn't mean they're hospice, right? You can be palliative for years. So morphine and other opioids can easily cause lethal respiratory depression. What about that?
No.
It can, or they can,
But not
They're
easily.
just
But-
really potent.
pardon?
They're just really potent.
They're really potent, however, it depends on what kind of dosage. If you got a real high dosage of morphine or any of the other opioids, you can kill the patient, and it is usually via respiratory collapse. But if they're careful with the medication dosage, then no. Pain medication should be given only after the resident develops pain. That's interesting. So pain medication should be given only after the resident develops pain. Now, there are two ways to look at this, but
Well, you don't if you're doing like a procedure like your wisdom teeth, right? Like they don't wait until after they start pulling to numb you.
right? Yeah.
So
Okay.
if it's something that you know that they're gonna be in like increasing pain, like labor or something.
Yeah. The other way to look at that, that's one way to look at it, and that's reasonable. The other way to look at that is if you're prescribing pain medication to someone in pain, you don't wait until the pain develops. What they say is morphine Q 4 hours, something, right? But a lot of the patients that don't like taking medications will wait until the pain recurs before they take another dose. But you're supposed to take it on a 4-hourly basis so that the pain never recurs. That's the other way to look at it. So you shouldn't take the medication until the pain starts. You should take it on a normal loop. So anxiety always makes pain worse. Anxiety always makes pain worse.
Probably can, but it's not like a fact.
Okay, yeah, it can. Consequences of untreated pain. What happens if pain isn't properly treated? And this is the patient who doesn't want to take pain medication until the pain comes back. Poor appetite and weight loss. Disturbed sleep. If you're in pain, can you sleep? Probably not. Unless you get some medication to put you to sleep. Poor appetite and weight loss. Yeah, you're in pain, you don't want to eat. Withdrawal from talking or social activities. Yeah. If you're in pain, you don't want to go out. You don't want anybody to come in.
You don't want to do much of anything.
Yeah, exactly. Sadness, anxiety, or depression, or all three. Again, you're in pain, especially if you're chronic pain. Physical and verbal aggression, wandering, acting out behavior, and resisting care. Yeah. You're in pain, you don't want anybody to help you because they may cause you more pain. And again, difficulty walking, transferring, may become bedbound. So if you're in bed and nothing hurts, why on earth should you get up and try to walk? Because it'll hurt. If someone's going to try and get you from the bed to a wheelchair, are you going to let them? No, because it'll hurt. You're lying in bed, doesn't hurt. Go away, leave me alone. Okay, skin ulcers, incontinence, increased risk for use of chemical and physical restraints. Okay, skin ulcers, bed sores, as they're called. Has anybody seen any bed sores? They're really nasty, some of them. And there's no excuse for them, even in long-term care. There's no excuse. What causes it? What causes
Staying
bed
in one
sores?
spot.
Pardon?
Staying in one spot.
Lying in one spot for too long, yeah. So normally what happens if your patient is in bed, you should rotate, it sounds silly, rotate them every, it sounds like a joint of meat or something. You have to move them every couple hours so that they're not lying on their back all the time. They're lying on their side and they're lying on the other side, or they're lying semi-prone, so that they're, and where do they usually hit? Where do the bed sores usually hit? Where do you find them most of the time?
On the back.
On the back? Where on the back?
Like that.
Yeah, you can find them actually all the way down the spine, but usually it's right at the base of the spine, right in the buttocks, or north of the buttocks.
Don't some hospital beds like shift the pressure on its own, like it's set to do that?
Yeah, there's what they call high loss beds or low loss beds, where they can alter the weight, but you still have to move the patient. There's no, you can, they will move for you, but it's not as good as actually physically moving them.
If someone's in the hospital for like a month or two, are they kind of like inevitable at some point they're gonna get a bed sore? Even if they're moving them all the time?
Even if they're moving them all, yeah. No, it's not inevitable. It's bad nursing.
Okay.
In all seriousness, yeah, it is. You should never, even if your patient is in long-term care facility in a bed all the time, you should never have bed sores. The combination of good nursing care and these fancy beds should eliminate it altogether. And the fact that, you know, some people, you can get up and move around and sit them down for a while and then go back to bed and roll them one way or the other. Incontinence, either of urine or feces. Unfortunately, that's one of the problems you'll see if you have patients from a nursing home. A lot of time you'll find them in adult diapers because they're either incontinent of urine or incontinent of feces or both. And that is unfortunately one of these things that you have to deal with. And it could be for lack of, they may not be eating well, or their medication isn't keeping up with either the diarrhea or the constipation. There's some overdoing the constipation, therefore they may have diarrhea. or vice versa. Physical, sadness.
You went back a
I
slide.
went back, I'm sorry, yeah. Increased risk for use of chemical and physical restraints. Okay.
Well, it goes back
What
to like
are
the anger.
chemical restraints? Physical restraints, we know, they're the soft cuffs, right? They're usually sheepskin type things. They're still restraints, but they're soft, so they call soft cuffs. What's chemical restraints?
Sedatives.
Sedatives. Or, yeah, some kind of sedative. Unfortunately, you know, Mrs. Jones is she's in all sorts of trouble, so let's give her a sedative. That's not good. Decreased ability to perform activities of daily living. So the patient perhaps used to get up and at least wash her face or wash her hands or go to the bathroom by herself or something like that. Now she can't do that. Or she won't let you help her do that. Impaired immune function. So if you're not eating well, you're not getting exercise, if you're not getting exercise, you're not getting out of the building, you're immunosuppressed. So again, you have to be careful of that. Okay, acute pain. Brief duration goes away with healing, usually 6 months or less. So I was going to ask you the examples, but it's down here. Okay. Not necessarily more severe than chronic, maybe sudden onset or slow in onset. So broken bones, strep throat, and pain after surgery or injury. Anybody give me any more examples of acute pain? Acute pain, broken bones, strep throat, pain after surgery or injury. What about pain before surgery or injury? Something like appendicitis. Anybody had appendicitis? Nobody's had appendicitis. Okay, I can assure you from experience, my experience, it is painful. That would cause acute pain. What else? Headaches. Headache would be acute pain, unless it's chronic, as in migraines. Migraines would be counted chronic pain because they're ongoing, right? So headaches. Anything else? So how do you treat chronic acute pain? Well, you find out the cause. If it's broken bone, you fix the bone. If it's appendicitis, you take the appendix out, and hopefully that'll work. Strep throat, you take the medication and it goes away in a couple of weeks or earlier. Okay, chronic pain, chronic cancer pain. Pain is expected to have an end with cure or with death, surely. Okay, aggressive treatment. Addiction, not a concern. So we've been talking about cancer treatment and cancer as a rule. Cancer as a rule is not painful. You have breast cancer, which is a painless lump. You have Hodgkin's disease, which we just finished, which is a painless lump. Most cancers, and that's the problem with some cancers, is that if it's painless, it can be serious. Unfortunately, it's usually the opposite way around. If it's painful, then it's usually not quite as serious as the painless stuff. But if you go into cancer pain, for example, if the cancer spreads to the spine or the hip or any of the bones, that can be painful. And that is counted chronic pain because it's there until we either treat it or you die. We get rid of it or we don't. Pain has no predictable ending. Difficult to find specific cause, often can't be cured, frequently undertreated. This is chronic non-malignant pain. So you have a chronic bad back. You have a chronic pain in your back. What do they do for it? You take maybe pain medication. You take maybe muscle relaxants. Does that help? Sure. Does it cure it? No. So chronic pain is there for a while. So how do we treat chronic cancer pain? Do the surgeons go in and do something? No? No? Yes? No? Maybe?
Not for pain.
Not for pain, not for, yeah. So it's bone pain. If it's spinal pain from cancer, from a lesion, there is something that the surgeons can do sometimes. They can do what is called a laminectomy, which they take out the disc and they fuse the bones. That might help the pain. They can also, the other thing that they can do is they can go in and fill the bone where it's been eaten away by cement-like stuff. And that can sometimes ease the pain quite considerably. But majority of the time, it's up to radiation therapy to help bone pain. And radiation therapy does help bone pain, cancer-induced bone pain. Could also help chronic arthritis, but we haven't used it for that in a long time. Anybody heard of something called ankylosing spondylitis? No? Yes? We used to treat that as well many years
It's the
ago.
back, right?
Yeah, it's the spine.
My son has that.
Yeah. Well, we used to treat that many, many years ago. I don't think
Oh.
anybody would think about that
They don't
now.
offer that now.
No, of course not, no. But it worked, it really worked. So unfortunately, chronic non-malignant pain is usually the back or the hip or whatever. So if you have a bad hip, can they do anything for it?
Hip replacement.
Hmm?
Hip replacement?
Yeah, they can replace it. You can get a prosthesis. Does that help pain? Yeah.
Yeah.
because you're taking away the pain from the hip, because the hip is no longer there. You put on a prosthesis. Mind you, you still have to get used to the prosthesis. But as far as malignant pain goes, they won't necessarily do that. They'll pin it. If you have a broken arm, if you have what is called a pathological fracture, so for example, you have a breast cancer, it's spread to the humerus, and you're taking your dog for a walk. This has actually happened to one of the patients. Taking a dog for a walk, and the dog sees a squirrel, and what does he do? He jerks your arm with your leash, and you let the leash go and it hurts. So she takes the dog home, goes to see the doctor, they do an x-ray, and she's broken her humerus from that jerk of a dog. The jerked line, the jerked leash that the dog, when he wanted to go after the squirrel. It can happen as easy as that. I've seen patients who have had rib bends from breast break a rib when they coughed too hard. So it's very easy to do that. And what they'll do for the humerus is they'll pin it. They'll put a pin on, and then we'll treat it to help calcify the lesion, and it'll make it stronger so that it'll probably not happen again. That's not to say that she might break her other arm. So here's pain by type. Oh, you guys want a break? Yeah, let's take a break and we'll come back to that.
Set an alarm.
Okay. Door, please. Thank you. You know it was a bad idea to sit there, right?
Oh, come on.
So who's doing their presentation tomorrow?
Not,
What you doing on ultrasound? Ultrasound?
Angiography.
And geography, okay.
is it just y'all tomorrow?
I think Molly was supposed to do it tomorrow too, so she may not, she probably won't be in.
Well, I hope he doesn't ask me to go early. That's enough.
And I'll log you in as well, so. Okay, so let's get back to this.
Nap time.
Yes.
Okay. Yeah, okay. So, somatic. Sources, skin, muscle, or connective tissue. So, examples of somatic pain are headaches, sprains, and arthritis. So, localized, sharp or dull, worse with movement or touch. So, if you think about sprains, if somebody touches your sprained ankle, for example, it's gonna feel worse if somebody actually tries to manipulate it, right? And arthritis, sometimes it's the same thing. So most pain meds will help. If severe, you need a stronger medication. So for all pain, what should you start with? What kind of medication should you start with?
Over the counter, just.
I was thinking basically mild, yeah, but over the counter. Mild, like ibuprofen, aspirin, depending on whether you can take aspirin or ibuprofen, whichever it happens to be. Or even the wraps that you can get now, the pain patches, not fentanyl type pain patches, but the pain wraps that you can get, which of course don't have any meds in them. So visceral, which is internal organs. So tumor growth, gastritis, or chest pain. And the description, not localized, refers to constant and dull, less affected with movement. So you have pain meds, stronger pain medication. So, gastritis, tumor growth, chest pain. So what kind of pain medications are we looking for there? Obvious one would be chest pain. What kind of meds do you do for chest pain? So if you have someone with chest pain, what are they likely to be on? Something that goes underneath the tongue. Nitroglycerin, yeah, nitroglycerin. That is still counted pain meds, only there are. So what would stronger pain meds be? Tylenol 3s, Tylenol with codeine, yeah. We're not in the opiates yet. Opiates are final response. Bone pain. Source, sensitive nerve fibers on the outer surface of the bone. For example, cancer spread to the bone, fractures, or severe osteoporosis. It tends to be constant and worse with movements. So pain meds, it says, stronger pain meds, opiates with NSAIDs as adjunct. So you can get, the idea is that you give opiates which are long acting. And then you give the likes of NSAIDs or Tylenol, something like that, as what they call breakthrough pain. And if they know what I mean by that? No? Okay. Breakthrough pain is when the opiate pain medication is say it's every 6 hours. At about 5 hours-ish, there or thereabouts, it's starting to lose its control. So it's not controlling the pain anymore. So you give Tylenol 3s, usually with codeine, Tylenol 3 with codeine, as a measure to tide you over before the next 6-hourly medication. So it would be given round about the 5-hour mark to the 6-hour mark, or the 7-hour mark, because the 6-hour pain med takes a while to start taking effect. So you've maybe got 2 hours where it's starting to lose effect, and then you're starting to gain effect. So that 2 hours is what they call breakthrough. And that's when you put your Tylenol with codeine or whatever your breakthrough meds are. Or you can do patches. Okay, neuropathic, nerves. So examples, diabetic neuropathy, phantom limb pain, cancer spread to nerve plexus, description: burning, stabbing, pins and needles, shock-like and shooting pain. So opiates, I can't spell, opiates and tricyclic antidepressants or other adjuvants. So again, you have the opiates with a breakthrough med. And sometimes, this is where sometimes the fentanyl patches come in, or the more MOS patches come in, and you still need this breakthrough pain the breakthrough pain medication that you sometimes need. So, talking of fentanyl, anybody know how strong fentanyl is?
Insanely strong.
Okay. Give me how much stronger is it than morphine, for example?
I'm not sure, but I do have an example.
Okay.
When I was in academy with the FGOC, we had a prison down towards Miami. Don't know the exact name of it, but one of the inmates had gotten baby powder in a pillowcase and placed it with fentanyl and got it up in the fan in the ceiling inside the wing, flapped it into the fan, and the fan through the whole wing and killed like 40 something inmates.
Holy
right.
crap.
So the problem is with
That's
fentanyl is if you get it in the powder form. If, for example, the cops are doing a drug raid, if they even touch it with their bare hands, it can be deadly. Sorry?
Why would anybody want any of that stuff?
Yeah, well, it's that they're now cutting opiates with fentanyl. So it makes it stronger, but it also makes it deadlier.
How did you get?
How did they get it? They get it very,
You should watch
Yeah.
60 Days In.
It's
very, very.
They get
very
it
easily,
crazy.
yeah, very easily. And the problem is that it is so easy to come by because there's a lot of patients that are on fentanyl, especially the patches, that they steal them. They steal them from the patients. I had a lady whose fentanyl patches were stolen out of her house by a grandson, and he sold them on the street. So what they do is they take the patches and split them, and they get the fentanyl out. And because it is meant to be used for 24 hours, these patches are usually used for 24 hours, it is very strong. So they can use that. So it's really nasty, to be honest. But I mean, some people need the fentanyl patches, and it's a very, very good drug when it's used properly. We used to use, it sounds silly, but fentanyl lollipops, and basically what they were, we used them for pain control on patients when we were doing gynecological implants. And patients that didn't want to be put under general anesthetic, we'd give them these fentanyl lollipops. And what they were for all the world like a lollipop stick with a little white top. And they were fentanyl. So you basically sucked them and the pain was gone, or whatever pain you were going to get was gone. And that worked as I won't say a local anesthetic, but the patients couldn't care less what you did with them then, because they were high. It didn't last for long, but And they had to be locked up, double, triple locked, because they were easy to use. So anyway, I don't think they make them anymore, to be honest, because they're too easy to take. So, asking about pain is an important part of all assessments. Anyone caring for a resident or a patient for that matter is to know how to report pain. So, you're treating a patient who you know is got spinal meds, and you're treating it, and you know they're on opiates, whatever opiate it happens to be. So you ask them how the pain is, and they'll say, okay, it's not bad, it's under control. So what meds are you on now? And they'll tell you, and they'll say, how often are you taking them? Oh, whenever it gets too sore, or it gets too painful. Is that the way to take pain meds?
No.
So, okay. And then what do you say to that? You tell them, or you ask them, how was it the doctor told you to take your pain meds again? Well, he told me to take them every 4 hours. And why aren't you doing that? Well, I don't like taking them. I don't like taking pills. Oh, it'll be easier on you. No, I don't think so. Yes, it will. Oh, it will. Yes, it will. Anyway, you can't force people to do things. All you have to do is encourage them to follow the rules that the doc has set down. Whether they will or whether they won't. Okay. So, ask the patient if he or she is having pain. Consider the disease, condition, and procedures that may be causing pain. I think if I were that person, would I want something for the pain? Probably. However, you've got problems with patients. Oh, here's a little twist. Dementia or communication problems. Yes, before somebody asks, we do get patients with dementia and or Alzheimer's. They're different, of course, right? Everybody knows that, right? Dementia is not Alzheimer's. Alzheimer's is a type of dementia. So are they able to tell you what meds they're on? Maybe. Sometimes most dementia patients, and I'm doing a sort of block thing here, most dementia patients are better in the mornings than in the afternoons. They have what is called a sundown effect, whereas the afternoon wears on, their brain just seems to go for a sleep, as it were. So they're better in the mornings. So this is a thing. If you have a patient with dementia or Alzheimer's, we'll call it dementia, is there anything different you would do if we were treating them?
Maybe like make sure you communicate more with them.
Mm-hmm. Okay.
Maybe go slower.
Sorry?
Maybe go slower. You're not like moving
Slower?
too fast.
Okay, go slower. Are they likely to understand what you're going to be doing to them?
Why not?
No. They've probably forgotten from yesterday. They usually come in more than likely come in with somebody, either a caregiver or a relative that can speak for them. But it's just you or the group of you, whoever there's there, 2 or 3 of you, that are alone with the patient in the room. So you have to be slow and distinct to what they need to do. And you say, do you remember what we did yesterday? And they'll look at you and say, was I here yesterday? You think, okay, we'll start from scratch. So you, although most of the patients, you say, okay, we'll do the same as yesterday, no problem. She gets on the bed, da-da-da-da-da-da-da-da. With an Alzheimer's patient or a dementia patient, you can't do that. You have to basically start, every day is a new day. Every day you have to start from scratch. You have to explain very distinctly, very slowly, what they have to do. And there may be they may not want to do it for you. No, I don't want to do this. Well, you know, you have to do this because we want to make you better. No, I don't want to do this. So at that point, you can't force them, right? Even if they have dementia, you can't force them. So you go out and get whoever's with them, whom you hope has some type of rapport with them. And they come in and say, okay, mother, we're going to do this. No, I don't want to do, oh yes you do. Come on, let's get you up on the bed and get you sorted out. We'll do this. Now all you have to do is lie still. Oh, okay. And they'll lie there for about 2 minutes and they'll say, what do I have to do again? Or are we done yet? Or can I move now? It's like treating a child. But obviously you don't treat them as a child. You treat them as an adult. You try and get the point across. Sometimes it doesn't work, but you try. And that's the problem with sometimes. And they'll sometimes scream and yell, and you just have to go about and do what you need to do. Thank goodness there's always somebody with them. Okay, communication difficulties. So use proxy pain reporting, so family and staff. How's she doing today? How's the pain, do you know? Is she moving around? Does she have diarrhea? Does she have vomiting? Da, 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 da. Be alert for behaviors that may indicate pain. So if you lie them down and they're sort of like this, they're maybe not in the most comfortable position. Facial expressions. If you lie them down and they're going like that, what does that mean to you? You remember it's like that? It means they're in pain or they're uncomfortable anyway. It could be they just don't want to be here, and you know. Physical movements. Oh yeah, that's a beauty. Okay. So you try and put their hands on their chest and they're doing like this. So you put, well, do you want a seatbelt? We can give you a seatbelt. Okay, so you put a seatbelt around and they're looking at this and they're getting up. Vocalizations, the scream and yell thing. Social changes. Yeah, well, sometimes they'll do things like, we've had people that, you know, they're well, I need to go pee, and they start taking off their skirts, or they'll go down inside their pants and start trying to pull off their diapers and stuff. They want to go to the bathroom. Better still, they start taking off their clothes as they're going across the hallway. Yeah. And last but not least, aggression. They have no filter sometimes. Patients with Alzheimer's, they have no filters. They'll say exactly what they want to say, and the language sometimes can be colorful. We had a lady, when I worked in Calgary, we had 5 floors. And on the 5th floor, we had an oncology room, an oncology floor, nursing floor. So we'd have to sometimes go up and get our patients from the 5th floor. The 4th floor was a psychogeriatric unit. And they found out that if they pulled the doors were locked and the elevators were locked. So you needed a key and a code to get out of the floor. But some bright spark of a Alzheimer's patient just figured it out that if he pulled the fire alarm, the doors opened. So every so often you get this fire alarm. Fire alarm, 4th floor, cancer center. You think, oh, okay, done again. And there was this little lady, and I swear she was about 4'2", and she was a nun. And she still wore her habit because nuns are nuns are nuns. You know, you don't retire. And she had Alzheimer's. And she'd swear like a trooper. She'd go down the hallway, and you get this little nun, quite knee high, in her full habit, and she's swearing. and she'd get out of the floor and walk down the stairwell, and she'd be swearing because she wanted to go back home, and nobody would let her go back home, and yeah. Anyway, so aggression, sometimes it can work 2 ways. They can either be very quiet and very demure and not say anything at all, or they can go the opposite way. Yeah. We had another story, and I'll stop my stories there. We had this 4th floor didn't have many male staff members. And my husband was a nurse up in one of the other areas. And he used to get called because they didn't have many male nurses. So he'd get called, and off he went. And there's this little old guy who was 103 or something. And he was chasing this nurse down the hallway with his stick. And Tom came out of the stairwell, shut the door, and this nurse came running after him, got behind him and said, "Stop him! He's chasing me up the hall." So Tom looks and said, "Mr. whatever his name was, drop the cane." And he looked at him and he said, "Drop the cane." And he dropped the cane and simply fell down on his butt. Because he couldn't walk without the cane. But he could chase the nurse, he still had his cane, and he could walk with his cane. But as soon as he let it go, he couldn't walk anymore and fell on his butt. Anyway. Aggression. That's sometimes the problem. I'm not saying that everybody you'll come across with dementia is aggressive. It can be quite funny sometimes. Sadly funny, but funny sometimes. Okay, to use rules of thumb, use the lowest effective dose by the simplest route. So what is the simplest route to give meds? What's the simplest route? Oral. You don't want to give somebody an IV and have them attached to an IV pole if you can possibly help it. So the simplest route, if you can get it in, is oral. Start with the simplest single agent and maximize its potential before adding other drugs. So, patient has a headache. You're going to give them ibuprofen or Tylenol. And if one ibuprofen doesn't work, you give them two, depending on their weight. If you have a little skinny little lady, 2 Tylenol probably or 2 ibuprofen will work for most things. If they only have a headache or they've got a sprain or whatever. Use scheduled long-acting pain medication for constant or frequent pain with PRN short-acting medication available for breakthrough. Just we were saying about breakthrough. So, long-acting pain medication. Long-acting morphine, long-acting oxycodone, long-acting fentanyl with short-acting medication available for breakthrough. What's PRN? Pardon? As needed, yes. Treat breakthrough pain with 1/3 the 12-hour scheduled dose. So, you've got 12-hour dose, so you've got 8 till 8 or 7 till 7. You probably would start the breakthrough pain at 6 o'clock. And the new one would start at 7, so till 8, just to give it time to get more. If 3 or more PRN doses are used each day, increase the scheduled dose. Increase by 1/4 or 1/2 the prior dose. So this is just background. You're not going to do this. This is just background, so you know. Be vigilant in assessing the side effects of medication. Treat or prevent side effects, such as constipation or nausea. And medication should be changed if necessary. So if you know you're on opiates, chances are you're going to get constipated. So what do you do to stop constipation? Do you change from opiates? You need the opiate. The patient needs the opiates. But you know they cause constipation. So what do you do? What do you do to stop or what can you do to mitigate the side effect of constipation? Pardon?
Give them a stool softener.
Stool softeners or laxatives, mild laxatives like Senecot or something like that, or the stool softeners. Yeah, you always have to do that, otherwise they'll get so bound up that you don't want to go there. And if a certain medication causes nausea, then you give them antiemetics. Reevaluate and adjust medications at regular intervals. Do not stop medications in terminal patients. Change the route if needed. So, little attention in the literature for physicians and nurses on the topic of pain in the elderly. Cognitive impairment, institutionalized elderly, often stoic about pain. Cognitive impairment, delirium, dementia, prevent barriers to pain assessment, just like we were saying. You really don't know what the patient's feeling, or whether the patient, how the pain is working, or how the medication is working. You're going with a third hand because you can't ask the patient's caregiver or relative doesn't really know, perhaps. The patient has no idea what you're talking about, perhaps. Sometimes they're lucid, depending on how bad the Alzheimer's is at that point, or dementia is. But if they have lucid times, then you can talk about the pain medication or the other medications or whatever they happen to be on. But other days, they're just doolally. Sorry, nobody knows what doolally means, right? I'm sorry. They are they're in a world of their own, shall we say. That's what doolally means. They're way out there. Opioids produce higher plasma concentrations in older persons. Greater sensitivity in both analgesic properties and side effects. Smaller starting doses are required. Consider duration of action, formulation, availability, and side effects. And review for drug interactions. Most of these ladies, especially, or most of these patients, especially if they're in long-term care, have dozens of medications that they're on. If you start something new, then you hope that whatever pharmacy is giving them the drug checks for drug interactions. That's sometimes the beauty of the electronic devices that we have these days. That the pharmacy can actually do that. Fluctuating pain levels. Long-acting are generally suitable once steady pain levels can be achieved. Okay. Fentanyl patches should not be placed on areas of the body that receive excessive heat. Patches may be contraindicated with exceptionally low body fat. So if you're in Florida and you have a patient on fentanyl patches, where should it not be? Where do you not want to place it?
On the face.
Yeah, well, nobody would put a fentanyl patch on. Yeah, okay, yeah. So where normally do you, anybody know where you put a fentanyl patch? On the back, usually here, on the shoulder, because it's easy to reach for most people. However, depending on what kind of clothing the patient usually wears, if you're wearing strappy tops, do you want to put it there? Probably not. Because if they're outside in the sun, most long-term care facilities like to get the patients outside for a little while. If they're outside in the sun and you've got this fentanyl patch on that's, you've got the middle of July, you don't want a patch there. So you want it maybe down here somewhere. And again, if you've got one of these little skinny ladies who has very little fat on their body, then the fentanyl is not acceptable for somebody like that because they can overdose them. Frail elderly patients at risk for both under and over treatment of pain. NSAIDs and acetaminophen are effective and appropriate for a variety of pain complaints. However, NSAIDs, they have problems, they give you problems with stomach and kidneys if you overdo it. Unusual drug reactions, most common in the elderly, but you should have to be aware of what might be a side effect, what might not be. So make sure that everything, obviously this is for patients that are in a long-term care facility. We wouldn't do things like that, although we would talk to the person coming in, communicate with everybody else, let them know what's working. If they're coming in, if the patient is coming in from a long-term care facility, they come with somebody. Make sure that they know what you're doing. Make sure the patient knows if they're able to communicate. A lot of these ladies or the patients are in long-term care facilities because they got nowhere else to go. They may be talkative, they may be very bright, so there's no problem with communicating, but you have to let the person who brings them know as well, so that they're up to date on what it does, what they do. Questions? Think of anything else? Oh, okay. Pain is not a plan. Understand the care plan for pain and pain. Oh, pain management, I'm sorry, pain management of the team. Okay, I shouldn't have said that. Okay, so the other thing is pain control. Obviously meds, but there are pain control methods. Massage works very well. Music therapy, pet therapy, biofeedback, I've never been able to figure that one out anyway, but biofeedback works. Art therapy also works. And play therapy, believe it or not. We, in South Florida, before I moved up here, they opened a brand new hospice center, and we all went over to see what it was like because we were getting patients from there. And we wandered in, and there's nobody around, but we heard this noise coming from down the hallway, and we thought, okay, let's go investigate. So we went down the hallway to investigate. And here's all the residents in this big, huge dining room that had been, the tables had all been moved apart. And they were playing, everybody knows what Wii is, the game? Mm-hmm. They were playing Wii bowling. And they were having a heck of a time playing this stuff. And I'm thinking, okay, play therapy is another one. So, music and art therapy, meditation can be done. Pet therapy is very good. You get these people who come in with their dogs or their llamas or their mini horses or whatever it happens to be that wander around the nursing homes. It's really quite amazing how much you get these people who sit and do nothing all day, and as soon as they see a dog or a parrot or, I know parrot's strange, anyway, but llamas or mini horses or something, they'll brighten right up and start talking to them. So it really is amazing what we can do. We used to have dogs come in every morning into the radiation therapy department in California that I worked in. Every morning we had a dog. and he'd just sit there and let people pet him. And he'd come over, and there was a stash of dog treats, dog biscuits, and he knew exactly where they were, but he wasn't allowed to go. So he'd sit there and he'd look at the pet, and you'd look up at you and his big brown eyes. I know what you want, so you go patiently go over and grab it, and then go to the next one. And he'd yeah, they were very bright, these dogs. Except one lady who was scared of dogs. She couldn't sit in the waiting room, so she had to sit in another area. What?
What type of dog was it?
Yeah, well, we said, they're really nice dogs, and we're quite happy to bring them, no, I can't do that. So she wouldn't be in the same room with the dog, let alone, because what happened was their owners would bring them in and ask anybody if they didn't like dogs, so the dog wouldn't come near them. But this lady wouldn't even be in the same room as the dog. So, anyway, questions on pain control or other things? Pharmacology. I'll send you that information tomorrow and see how things go, okay? So I guess I'll see you for a little